So, hi guys, welcome to the Finals Crash Course series. We'll be covering anaesthetics and cardiothoracic surgery. We've got Dr. James Sweatman here, who's an academic F2 at St George's, who will be running the session today. We've also got their Instagram link as a QR code up on the corner as well if you want to follow us on Instagram, and I'll email down at the bottom if anyone wants to email any queries in. So James has come up with a polling system, which we'll be trialing out tonight. So we'll see how it goes. So I'm going to hand over to James.
Cool. Hi guys. So my name's James. I'm one of the F2s at St George's, as has been said already. So we're going to go through anaesthetics and cardiothoracic surgery this evening. What I've been told is that on previous sessions, you guys prefer to have SBA-based teaching. So what I've tried to do is take my mind back to 2 years past where I was doing my finals and try and think about what those questions were like and try and relate it to what you need to know about anaesthetics and cardiothoracics, which are quite niche topics when it comes to finals preparation. So there's not an awful amount of stuff that you really need to know that's high yield. So we'll go through some of that stuff, and that should hopefully be pretty much everything you need to know for finals. We are going to try and do some polling because obviously if it's SBA questions, then it only works if you guys are going to answer the questions with me. I didn't want to unfairly make you call out stuff because I hate doing that when I have teaching. So if you guys got your phones around, that would be very helpful because you can scan the QR code and we can have a look at kind of where people are as we go through. All right. Cool. And I'm going to turn my camera off so that you don't have to look at my face through the whole thing. If you've got any questions all the way through, like, just feel free to shout. Okay. So structure for this evening. So we're going to split it into 2 parts, and then we'll have a bit of a break in between for you to kind of go to the loo and get a coffee or a glass of water or whatever. We'll have a very, very short introduction to each specialty, which is basically just what do you need to know about that specialty and what do they do. And then we're going to focus on the SBA questions. Please do try and answer the questions because it's really useful for me to know kind of what bits of the presentation or bits of the question we need to go into more, depending on what people are choosing and whether they're getting it right or wrong. So if you all get it right, we're probably going to spend 15 minutes on it. But if everyone gets it kind of really wrong, then we might need to spend a bit more time on it. And then we'll work through the answers afterwards. So they're worked answers so that you can see how I wrote it and what I was looking for in the answer. The anaesthetics bit is going to be the longest bit because there's way more stuff in anaesthetics. And then cardiothoracics is going to be much, much quicker. So topics that aren't going to be covered. So as I said, these are kind of weird specialties for finals. I don't remember being asked very much at all about these topics. So I've tried to write questions that allow us to talk about all the important things you'll need to know and you'll be tested on in finals. So don't think the questions are just going to focus on anaesthetics and cardiothoracics. You will need to engage all of your bread and butter medicine brain in order to think about these questions. The finals questions, thinking back and talking to my colleagues about what it was like doing them, they are very notorious for tempting you to pick an obscure answer that you kind of remember from past medicine. And in general, I think my experience was that the finals questions were very past medicine-y. But obviously it will depend on what medical school you go to, because I think 50% of them are tailored to your curriculum. So it might be different for you. So just look at the answers and try and think what is the right answer, not what's the obvious answer. Topics that we're not going to cover today are wound management, general post-op complications, and VT prophylaxis. VT prophylaxis, I would be surprised if you get asked any questions about VT prophylaxis in surgery, because it is so niche. You can look it up in the BNF, and it may be something that you were asked in a PSA, but probably not in a finals question. It's quite specific and local centre specific as well. Topics that are difficult to examine or not commonly examined: transplantation medicine, so we're not going to do that. but you do need to know about what vaccinations, so pneumococcus, kind of influenza vaccinations, and an awareness of immunocompromise when you see septic patients or you see medications. And also perioperative antibiotic prophylaxis, because again, that is kind of, there are guidelines, but a lot of the time it's kind of finger in the air. What does the consultant like? What does the anaesthetist think? And what's the status of the patient? And what's the operation going to be as well? So just thought I'd throw in some general tips for SBAs. So obviously you know most of these things, but what I think my takeaway would be that kind of first year level, the answer is pretty straightforward. You get asked, how does this channel work? And the answer is, you know it or you don't know it. Your kind of second set of examinations, you're often kind of needing to tell them what the diagnosis is or what the investigation would be for a diagnosis. So you're kind of like told, this patient's got celiac disease, what investigation would you request? At finals level, it's a bit more removed from that. Normally you have to get 2 or 3 levels of diagnostic leaps, or kind of 2 or 3 levels deep to the question to understand what you're actually dealing with. So often what you will need to do is look at the presentation and think, what's the diagnosis here? And then think what investigations they already had, or what medications they already had, and what would my next set of medications or investigations be? So you're normally trying to have to make at least 2 or 3 kind of layers of interpretation to the question in order to answer it. And that's the difference at finals. Obvious things, answer the question in front of you, not the one you want. This, the second one is dependent on yourself. I prefer to go to the actual question and then go back and read the stem so that I know what I'm going to be asked at the end, because some of the stems are deliberately long and blabbery, and you can often bypass that by just looking at the question and being like, okay, well, I already know that, without having to read the stem. Often it's a choice between 2 very reasonable answers, and that's the difficulty with SBAs. And the answer is often the safest or the most appropriate action. Most of the answers, like PassMed, are based on stepwise approaches. So what is next in the NICE guideline for this presentation, or what would you do next in a critically unwell patient following the kind of ABCDE protocol? And the most important thing is keep to your timings. If you get stuck on a question, just guess it, an educated guess, mark it, come back for it, come back and review it if you have time at the end. But there is no negative marking, so do not run out of time answering the questions. Stick rigidly to your timings in the exam. And the last piece of advice is, if you feel like you're in an SBA or you're in finals exams and you feel like you're questioning everything you know about medicine, that is completely normal. That is what the questions are designed to make you do. You just kind of need to take a deep breath, remember how much you prepared for the finals, how much you know. This is a culmination of 4, 5, 6 years of training. You know the answer, don't panic, just kind of think it through logically. Right, so anaesthetics. What does anaesthetics do and what can you be asked about it? Most people think anaesthetists are crossword professionals, which they are in a way. But anaesthetics is basically split up into 3 kind of subspecialties that you can be asked about. So the first one is general anaesthetics, and the things that you could be asked about in finals would be things like airway management. So how do you manage an airway? How do you recognize a compromised airway? The complications of sedation and anaesthesia, and basic pre-operative assessments, although that's a bit of a sideline, I think. Probably the one you'd be asked about most are intensive care medicine and pain medicine. So intensive care medicine will be A to E assessments and the management of critically unwell patients and the recognition and management of shock. And pain medicine will be basic pharmacology of analgesia. So how does this pain relief work? What are the side effects of it? What are the contraindications? Do you know your WHO pain ladder, or do you just skip straight to the morphine? And what are the contraindications, complications, and side effects of these medications? You won't be expected to be able to pick up a laryngoscope and RSI a patient as an F1, so we don't really get asked those questions in finals. but you will kind of need to know the basic pharmacology, emergency assessment, and stabilization of kind of really unwell patients, because that's what anaesthetists do. Cool, so let's jump into it. So if I can get you to get your phones out and scan that QR code, then you should be in the session. So you've been bleeped by a nurse who's concerned about a 25-year-old female who underwent laparoscopic appendicectomy 2 hours ago. She was initially stable, but her EWS is now 6. Her observations are as follows: temperature 40.2, heart rate 145, blood pressure 102/68, respiratory rate 22, SATs 93% and room air. On examination, she's extremely agitated with severe tachypnea and rigidity within her upper and lower limbs. Her chest is clear and the abdomen is soft and non-tender, and an ABG is performed, which shows those results. And the question is, what is the next most appropriate step in management? I've got 5 answers so far. We've got 11 people. Cool, we're up to 8. So we've got 3 more left. I'll give you 15 more seconds and then I will close it. So we've got 9, we've got 2 people left. Someone is really swapping and changing their mind. There's no negative marking, and I don't know who's answering. So
yeah, I think there's someone just wrote in the chat that they're not sure about reference ranges for the blood gases.
Okay, no problem. So we can go over that. Sorry, I didn't put reference ranges in. So the answer was C, and 40% of you chose C. So well done to those people. And the other responses were completely reasonable. So I can see why you wrote them. I mean, why you chose them. I mean, having written the question, they're all fairly reasonable things to do. So let's break down that question. All right. So the stuff that I've highlighted in yellow are things that are important, important bits of the case to know about. But the stuff in red are the really, really important things that are going to get you to the answer. So here we need to know that it's a pretty young, probably quite well patient who had surgery 2 hours ago. So in our minds, immediately, we should be starting to think, what causes complications 2 hours after you've had surgery? It's a really, really short, acute presentation. Then we know that she was initially stable, but now her EWS is 6, so she's not doing so well. The chest is clear and the abdomen is soft and non-tender. So in terms of pneumonia or aspiration or ARDS or anything like that, chest is clear. So it's probably not an infection or pulmonary edema or something weird like that. And the abdomen is nice and soft and non-tender. So she's not peritonitic. So she probably doesn't have a collection. They probably didn't forget to take the appendix out and now burst and she's given a frank peritonitis and stuff like that. The stuff in red are the things that you should look at and just be like, that's not normal. So the temperature of 40.2 is really, really high. So in general, any temperature that's above 40 is probably not your bog standard infection. Viral infections can vary occasionally, give you very high temperatures, but anything with a temperature over 40.2 is going to start making you think about weird and wonderful things like, is it drug related? So could it be serotonin syndrome, or is it endocrine related? So is it Graves' disease or something like that? Or is it the answer here, which is malignant hypothermia of anesthesia? And then we know she's not saturating very well, probably because she's panicky a little bit. And then the other thing that we've highlighted is rigidity. So rigidity is quite unusual. If you think about all the stuff that would happen post-op, so pulmonary embolism, infection, basal atelectasis, perforation. I mean, they don't give you rigidity within your upper and lower limbs. So that makes us start to think about possible neurological causes, CNS causes, drug-related causes, anything that kind of interacts with your motor neurons or your kind of CNS system. And then the ABG shows that she's in a kind of type 2 respiratory failure, although she's got a high lactate. Her bicarbonate is not massively low, and her base excess isn't massively swinging towards a metabolic acidosis. So predominantly, this is probably a respiratory acidosis and a type 2 picture. And the lactate is probably raised because she's just had surgery. She's probably hypovolemic to a certain extent. So the answer is administer IV dantrolene because the presentation is malignant hypothermia of anesthesia. And as we said, the cardinal features are normally it happens immediately, but it can happen a couple of hours after you're exposed to an anesthetic, and it manifests with a kind of quadrad or pentad of kind of extreme hypothermia, tachycardia, tachypnea, muscle rigidity, and mixed acidosis. So you normally get a lactic and a respiratory acidosis. So if you go back to the answers, the other answers, so CTPA, not correct because that's PE. She doesn't have a PE. PO2 is fine, and it doesn't give you muscle rigidity. It can sometimes give you a very mild fever, PEs. IV antibiotics, well, there's no evidence on the examination of infection. So her chest is clear, her abdomen is soft, non-tender. Yeah, she could have a cellulitis, or she could have a ulcer somewhere that's kind of a source for infection. But the things you'd think are the common post-op causes of infection, they don't seem to have any examination findings to kind of fit with that. And infection normally takes kind of about a day or two to start manifesting. And again, doesn't give you rigidity. IV fluid bolus, again, completely acceptable, especially with that lactate. But again, her blood pressure here in this rate is within the normal range, the kind of 90/60 that we kind of arbitrarily say is a normal blood pressure. But with the high heart rate, I can totally see how you would think that that's the first thing to do. And if you did that in real life, no one would tell you off for it. But obviously in an SBA situation, not the right answer. And a chest X-ray, obviously useful at some point, but probably not until we stabilize the patient because they're in a pretty bad way at the moment. So hopefully that was important. So let's talk about malignant hypothermia. So it's probably the only thing you need to know about anesthetics and general anesthetics for your finals. It's an inherited channelopathy that results in muscle hypermetabolism and acute rhabdo, basically. And what it is a kind of it's a mutation on your ryanodine receptors, which mediate calcium or intracellular calcium. And so when we give you inhalational anesthetics or succinylmethonium, which are the main causes, it kind of activates those ryanodine receptors, and you just start shedding calcium intracellularly, and that just stimulates all of your muscles to contract uncontrollably. And that's why you become very, very hot very, very quickly. That's why you get rhabdomyolysis, because your muscles are so active that they're breaking down and releasing creatine kinase. And that's why you get a lactic acidosis as well, because they go into that anaerobic cycle of metabolism. The increased heart rate and the increased risk rate, increased respiratory rate is mostly because of the hypermetabolism of the muscles. So you're literally squeezing your chest muscles very, 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 very quickly, and also affects the heart as well. But it'd also be because of the acidosis as well. To normally get a metabolic acidosis first because of the lactate, and then the mixed acidosis as your respiratory compromise worsens because of your worsening acidosis and your fatigue, your muscle fatigue. The management of it, so obviously prevention. You don't want to give succinylmethonium or sevoflurane to someone whose father had malignant hypothermia by accident. And then reversal of the agent where that's possible. So with inhalational anesthetics, it's just really high ventilation. With succinylmethonium, you can give neostigmine, and it's helping the muscles to relax. And that's what dantrolene is. It's a muscle relaxant. So that's the first line for it. And then all the things that happen after that be supportive care. So you actively have to cool them down. So that can be giving cooled fluids or kind of, passive cooling and active cooling methods as well. Cool. Any questions about that before we move on to the next one? I'm very conscious that IV fluids is on that management plan, but it's the dantrolene that's going to stop the presentation first. So that's the most appropriate next step. Cool. I've only ever seen this once, and it wasn't that bad. It's incredibly rare. most anaesthetists have never seen it. Cool. So next question. So this is a 75-year-old female who's found unresponsive on the ward. She underwent a total knee replacement 7 days ago. 2 days after her operation, she developed aspiration pneumonia and was started on oral coamoxiclav and metronidazole. Her observations are temperature 37.5, heart rate 62, blood pressure 102/68, respiratory rate 8, and SATs 94% on 15 litres. Examination findings: GCS 8, chest, right-sided crackles with intermittent snoring, and abdo is soft and non-tender. And what is the next most appropriate step in management? Cool, so we've got 8. We'll give it another kind of 20 seconds. Oh, someone's changed their mind. Right, you've got 10 seconds. Cool, I think that's all of us. Cool, all right, so well done. Most of you went for A, which is the correct answer, so let's insert a Goodell airway. And again, the other answer's completely reasonable. So let's go through why it's A. So this is testing whether you know your ABCDEs. So 75-year-old lady, unresponsive. So first things for your mind, I saw a lot of you going for blood glucose. Absolutely fantastic. If you find someone unresponsive, that's one of the things you should check. She underwent a total knee replacement 7 days ago. So a lot of you were thinking she's probably on some analgesia. So we might need to reverse that because it might be something like an opioid overdose, which is what I was hoping a lot of you were going to go for. And she's had an aspiration pneumonia as well. So is she floridly septic? And do we need to do something to escalate her antibiotic therapy? The main things are her respiratory rate is really low. She's on 15 litres of oxygen, so she's saturating normally, but on loads and loads of oxygen that's not sustainable for a long period of time. Her GCS is crap, and she's got snoring. And snoring is one of the cardinal signs that you are occluding your upper airway, normally with your own tongue, because your GCS is so low, but it can be just, particularly in patients with a high BMI, it can be just collapse of the upper airway from the weight of the kind of the neck. So this is probably could be a low BM, but it could be also acute opioid toxicity. So she's got reduced GCS, reduced respiratory rate. But it's not the only possible cause, and we need to remember when we go to these patients, we have to follow A, B, C, D, E. And the reason for that is the order in which people will die. So if you don't have an airway, doesn't matter if you fix their pneumothorax, they're still not going to be able to breathe and they will die very quickly. So in this patient, there's obvious evidence of respiratory compromise. And sorry, I meant to change that. It's not stridor. Stridor is different. The audible snoring is a sign that airways compromise is imminent, and we need to address that first. So measuring blood glucose, incredibly helpful and much more common than opioid toxicity. But obviously in an exam situation, we can't kind of pick and choose the findings that we have. And we need to prioritize airway and breathing before disability, which is where BM normally comes in. IV fluid bolus, IV Flamazanil is not indicated. So IV Flamazanil is a different presentation. And IV naloxone, which is the reversal agent for opioid overdose, should be given where there is a suspicion of opioid toxicity, but we need to secure that airway. I'm not going to spend too much time on this because I hope by this stage you guys remember your ABCDE. But just remember, if there's stridor or there's snoring, that upper airway is really at risk and you need to secure that, whether that's just suctioning them, putting them into the recovery position, trying your airway maneuvers, so your jaw thrust or your head tilt chin lift, and your airway adjuncts, because if they lose that, then you're a bit buggered. Breathing, so remember, kind of look, listen and feel, respiratory rate sats, get the monitoring on, consider banging on 15 litres of oxygen or whatever oxygen you think is appropriate if they're not critically unwell. Circulation, kind of always remember thinking about getting an ECG and checking the urine output, because I know those are things when I first started I kind of brushed over. You'd be surprised how many people post-op kind of develop atrial fibrillation, and that kind of makes them hemodynamically unstable. And remember to look at their drug chart as well in disability. So pupils, GCS-BM and drug cardex, that's the other thing that catches people out a lot in these types of situations. And then the key points about ABCDE that I often find teaching all medical students of kind of any age, and also kind of the F1s when we do sim training, is that with an ABCDE, if you find something wrong, you don't just go, oh, well, the patient's not breathing. Anyway, moving on to C, you have to fix that thing before you move on. So you have to make an intervention. So if you find something that's not right, intervene, whether that's with high flow oxygen or airway adjuncts or whatever it is. And then you can continue, and you should always come back and reassess whether that intervention has worked. So in this case, we're going to put a Goodell in the patient, and we're probably going, once we're happy that that snoring is gone, we're going to continue with our B, C, D, and E, and then we're going to come back to the top, and we're going to look at the airway again and see if that's still working, or if she's chewed it out, or if she needs an ET tube or whatever. All right, so always fix what you find and then reassess if you've done something. And I thought I'd just go over this as well because it can be complicated. The airway adjuncts, you always deploy them in a kind of stepwise manner, depending on the severity of the compromise. Okay, so nasopharyngeal airways, those things that you can stick in the right nostril and kind of put a face mask on, and it helps kind of deliver as much of that oxygen as possible into their airway. People who are awake can tolerate NPs pretty well, and we use them actually a lot in ICU for patients who just have a really kind of dodgy airway, essentially. We just leave them in there. Goodell's or oropharyngeal airways are the things you have to insert upside down and then twist and push to the back, and they go over the tongue and they stop the tongue from pushing back and occluding your airway. You can try and put one in if you're awake. It's not very pleasant, and patients who are awake are going to just spit them out. Okay, so these are for patients who are obtunded or have a low GCS. And then you got your supraglottic airways or your SGAs, which include both LMAs or laryngeal mask airways and iGels, and that's where the acronyms kind of get a little bit confusing. So the reason they're called supraglottic is because they sit above the glottis, and they kind of form a seal around your trachea, or the entry to your trachea where your epiglottis is. So iGels are probably what you're going to be seeing most commonly these days, and they're pretty good. And endo obviously goes out saying you got to be obtunded or unconscious just to tolerate one of those. And then ET tubes are what we call definitive airways. And a definitive airway is an airway that I have control over. It's not something that is going to allow a patient to aspirate. So with eye gels and LMAs, you can still aspirate some of your stomach contents into your trachea. With an ET tube, that shouldn't be possible unless the cuff is down, which sometimes it is by mistake, or it's got a leak in it, or it's faulty. But the reason it's called a definitive airway is that's an airway that we know is secure. That's the only one there. And obviously you've got trachees, which are definitive as well, but you don't put those in an emergency. And then obviously going from left is highest GCS of the patient. You can shove an MP into someone with a 15 out of 15 GCS. ET tube, you've got to kind of be unconscious. And then the definitive airway goes in the opposite direction. Hope that's useful. Cool. All right. Question 3. So 28-year-old unknown male brought into ED resus in a confused state. He was seen in the street acting strangely shortly before collapsing and becoming unresponsive. He was found with multiple strips of diazepam in his pocket. On examination, he appears unkempt with disheveled clothes which smell of alcohol. Examination findings: he's difficult to rouse as extremely sleepy, some snoring, 36.5 degrees temperature, heart rate 61, blood pressure 120/70, respiratory rate 12, SATs 93% on room air, GCS 9. And I'm sure Atch has seen these kinds of patients in resus. I've definitely seen these patients.
I've definitely seen these patients coming through the gen surge.
Oh my God, you always see them. The only way I can make this question more realistic is if they try and punch you while you go to talk to them. Okay, we've got 20. I'll give you 20 seconds. Okay, cool. I'm going to close it because we've got 11 in there. Finally managed it. I'm going to get some stick for this one, I think. So the answer from my perspective is E, which is give 2 litres. But I will go through why I think that's the right answer, because completely agree that all the other one, well, C is a fairly reasonable thing to do as well. And this is more based on my clinical experience than anything else. But I will take you through why I don't think it's 15 litres. Okay, so 28-year-old guy, taken diazepam, probably we think, and also taken quite a lot of booze, unresponsive, confused. You can still rouse him, so his GCS of 9 looks bad on paper, but actually in a lot of these patients, if you were to calculate their GCS accurately, it would probably sometimes be 6 or 7, but they're actually breathing and they're actually fine. They just really, really, really want to sleep and they don't want to talk to you. Hemodynamically and from a respiratory and cardiac perspective, he is okay, except for his slightly low SATs on room air. We don't know anything about this guy. We don't know his past medical history. We don't know if he's a long-term smoker. We don't know what he's taken. We're making assumptions here. So what I've said was this guy is working off a mixture of benzos and alcohol, which very, very commonly happens side by side. We don't know what else they've taken. We don't know their past medical history. A lot of you chose Flamazanil, which is the antidote to benzodiazepine overdose, but you never, ever give it. Almost none of you are ever going to prescribe it. Almost no one in ED resus would ever prescribe it. I've seen it used once before I knew better. It's always contraindicated in overdose, because the main thing is we don't know about these patients. We don't know what they've taken. We don't know whether they've been binging on alcohol for the past 7 days straight. We don't know whether they got epilepsy. and the benzodiazepine is actually protecting them against the side effects of other drugs that they've taken, which can promote and reduce the seizure threshold. So Flamazanil is the benzodiazepine antidote, but you almost never give it because the benzodiazepine is often protective of lots of other side effects of things that people have taken, particularly alcohol. So chlordiazepoxide, none of you chose. Good. It's a benzodiazepine. Probably shouldn't be giving any more to this guy. But when he wakes up from his alcohol-induced kind of sleep, he might need some DOLT and some chlordiazepoxide. The 15 litres I've put, from my judgment, is excessive because his saturations are only 93% and his respiratory rate is perfectly normal and his heart rate is perfectly normal. And it risks hyperoxemia or hypercapnia if this patient is a CO2 retainer, so if they're a long-term COPD patient. So what I would say from my chair is the most appropriate is to start low and see how he responds. And if he gets kind of 95, 96 on 2 litres, then that's fine. So we aim for a saturation of 94 to 98, unless they're really, really critically unwell. And then the chest x-ray, really, really useful at some stage because alcoholics and people who abuse drugs have all sorts of things that can happen to them, including kind of long-term empyemas that just suddenly causes masses of problems. But the management of the kind of overdose is best supportive care.
There's a question on the chat. So it's, when is Flamazanil given?
Not by you is the answer. So Flamazanil, it has to be prescribed by a specialist, and that specialist, I've never been told who the specialist is, but I imagine it's going to be either a neurologist or an intensivist. And it is given exclusively when you absolutely know for sure that it is just benzos that patient's taken. So the most cut and dry kind of situation I could imagine is I'm about to anesthetize someone and I give them accidentally 500 milligrams of midazolam to induct them and they become completely unresponsive. And then I give them Flamazanil because I know that I've only given them a benzodiazepine. But in all these patients who come in, you don't know who they are, you don't know what's happened to them, you don't know what they've taken. Even patients who come in and they swear blind that all they've taken is diazepam as an intentional overdose, you don't need to prescribe them Flamazanil. Often they will just sleep and they will sleep it off. Your role there is to kind of give them best supportive management and then just time. I have seen people who've been given Flamazanil and they are long-term alcoholics and then they develop kind of delirium tremens and alcoholic seizures from withdrawal. So you just have to be careful with that. I would never give it. As I said, I've only ever seen it being given once, and that was kind of before I knew what the risks were. But if you look on ToxBase, it will say, you know, only ever prescribed by a specialist. Cool. So in terms of overdose, opioid overdose is the most common form in the UK, which is why you guys all know the management kind of inside out. And the features of opioid overdose, there's a triad, classic triad of kind of low GCS, kind of less than 8, low respiratory rate, less than 8, and meiosis. Although you can get mydriasis in opioid overdose as well, but meiosis is more common. Very common in elderly patients on morphine, and again, another clinical kind of nugget that I've learned after 2 years: beware the sneaky boot-trans patch, especially the one who's got a package of care like twice a day, and different nurses come in and they just put another patch on every week and they don't take the other one off. And by the time the patient comes into ED, they got 50 boot-trans patches on various parts of their body and they've overdosed on buprenorphine, which does happen very, very commonly. The management of it is IV naloxone, and you can give IV naloxone kind of every kind of 5 to 10 minutes based on effect. It should reverse very, very quickly, but patients will often need more than one dose of naloxone. And then you obviously got to give supportive care. So maintain the airway and oxygenation and remove the opioids from their cardex, or at least think about what you can give as an alternative. In patients who chronically use opioids, naloxone sometimes needs to be used with a bit of care. But if they're very, very unwell, like they're obtunded, they're not breathing, I would still give naloxone to them. They will just have withdrawal symptoms, really, really bad withdrawal symptoms. Benzodiazepine overdose is pretty much the same. Sometimes, remember, benzodiazepines can have that paradoxical effect, so we often use it for sedation and make patients more compliant with procedures, but it can make you much more irritated, agitated, and delirious. So sometimes they come in, they're kind of fighting. Again, I haven't actually changed the features on that other side. So forget those two other things. And then the management of it is supportive management, as we said. So maintain the airway, maintain oxygenation, let them sleep it off, remove benzos from the cardex. Flamazanil, contraindicated, you get acute withdrawals, sometimes you get seizures, and only prescribed on specialist advice. Enough about overdoses. So question 4. 64-year-old man with a T4N0M0 colorectal cancer is due to undergo a surgical resection under general anaesthetic. His past medical history includes ischemic heart disease, chronic hypertension, chronic kidney disease, and COPD. He does not currently smoke or drink alcohol. He was recently admitted to hospital with central chest pain, following which he was started on oral furosemide 40 milligrams BD. And the question is, which of the following preoperative tests is not indicated? And I'm going to have to speed up to keep to my timing, so we're going to have to kind of limit the time you guys have got to answer the question. So I kind of give you 30 more seconds. Cool. All right. Awesome. So well done to 55% of you. So the answer was HbA1c. Let's go through why. So pre-operative investigations are all mostly tailored to the needs of the patient. Obviously, you've got to have some major things in there, like an FBC, U's and E's, an ECG. But the rest of them are kind of tailored to what's wrong with the patient. And the way I think about it when I'm in surgery is it's like a status report for systems you know are a bit dodgy. So the HbA1c would be really, really useful in someone who's a diabetic, who haven't had a recent one, like in the last 3 months. But for someone who isn't diabetic, you've got to ask yourself why you're doing an HbA1c in someone who doesn't have diabetes. You could say you're doing it in the off chance that you're going to diagnose them with diabetes, but then you'd have to have 2 HbA1cs because this person's not symptomatic as far as we know. So you could add it on, but we're supposed to be saving costs in the NHS, so probably not useful. Spirometry, we have to do it because this guy's got COPD. U's and E's, you need them in all patients. An ECG indicated in patients who are undergoing major surgery, just in case they have an asymptomatic arrhythmia, which can happen, or prolonged QT syndrome. An echo is indicated because he's probably had a heart attack and he's now got heart failure now because he's on furosemide. So the other way you can answer this question is to go through all the other options and rule out why you think you would do them. So you have to do the spirometry, you have to do the U's and E's, you have to do the ECG, you have to do the echo. So the only thing you don't have to do is the HbA1c. And I won't go through this, but this is from my notes, and this is the NICE guidelines for pre-operative investigations. So these are the things that NICE say you have to do for minor, intermediate, and major surgeries, and then the patient-specific investigations on the right-hand side as well. When you come to work in hospital, everyone who gets surgery gets a clotting. but the nice guidance is that you don't actually need to do it unless they've obviously got a clotting disorder, because most people have a normal INR. Cool. We're not going to spend too much time on that. Okay, question 5. A 58-year-old motorcyclist is brought into ED resus following a collision with a car. So we're getting exciting now. So he is initially conscious and speaking in full sentences. A chest X-ray is performed, see below, which is part of the primary survey. He is found to have a right humeral fracture and a small contusion of his liver. Later on, he starts saying that his breathing feels more difficult. His observations are as follows: temperature 37.2, heart rate 110, blood pressure 161/101, respiratory rate 26, SATs 94% on 4 litres. His ABG results are pH 7.32, which is low, so that's acidotic, PO2 10.1, so anything kind of above 8 on a PO2 is reasonable, a PCO2 of 6.7, so that's slightly high, a lactate of 1.8, which is fairly normal, and a bicarbonate 25.6, which again is fairly normal. Can you see that X-ray okay? Because what I do is I will zoom in to it. Hopefully that's zoomed in for you.
Yeah, I can see it. And also, if people want to just kind of zoom in on their screen, it does make it bigger there as well.
Cool. So you have one taker so far. Three takers.
Someone's asked if you can zoom out to see the options.
Oh yeah, sure.
Yeah.
Cool. So you got 7. I'll give you another 15 seconds. I've just noticed that on the slide it says NIV for option A, but it should be Bipap because that's what you're seeing on your phones. They're kind of synonymous, but they're not necessarily the same thing to all people. Cool. Okie dokie, right. So I'm going to say some of these questions are tricky. I've written them to try and be fairly challenging questions, just because I think really obvious questions probably not helpful for you at this stage. So the answer of this one is to commence BiPAP, and we will go over it. But before we move on to the reasoning, I'm going to go through this X-ray with you. So a lot of you have chosen insert chest drain or perform needle decompression. So what you can see on this X-ray, let me see if I get my pointer. Okay, bloody hell. Okay, so what you can see on this X-ray is you can see lung markings all the way to the edges, and I can't see any lung kind of marking, any kind of edge of the lung anywhere coming down through here. So normally you've got a pneumothorax is kind of like up here, especially if it's a direct X-ray, but you can't see any kind of lung edge on either side. It looks fairly normal. All right. Now what you can see here are multiple rib fractures, and here you can see 2 other rib fractures. So this is a flailed chest segment, and that will explain kind of why he's in an unhappy position here when we go on to the next slide. So the key here is the ABG. So he's acidotic. We know he's not saturating well because he's on 4 litres of oxygen and he's barely maintaining SATs 94 to 98, and his respiratory rate is 26, and he's telling us my breathing is really difficult. So once we see that, we need to see whether this is a respiratory or a metabolic acidosis. If we jump over here to the bicarb, it's not a metabolic acidosis because that's normal. So it must be a respiratory acidosis, and we can see that the CO2 is raised, even though just fairly marginally. Now, the next question is there hypoxemia with this? One thing that you need to take away about ABG results that I wanted to get across here is that this is normal if you're breathing room air. This patient is on 4 litres of oxygen. So in general, what you need to do, and you can do this on your phones when you kind of like are in clinical practice, you can Google what 4 litres of oxygen translates to in kilopascals, in partial pressures. And off the top of my head, I think it's like 36 or 38 kilopascals. And then what you do is you take away 10 from that number to figure out what a normal person's PO2 would be. So in all of you, if I gave you 4 litres of oxygen and I say it is 38 kilopascals, that's the partial pressure of 4 litres, and I gave it to you guys who've got no medical problems, then your PO2, when I measure it on an ABG, should be about 28. And the 10 that you take away is just to account for the gas that is lost in your conductive airways. So this is what's called a relative hypoxemia. So we are giving them oxygen, but their PO2 is only within the normal range of someone who would be on room air. So they are hypoxic as well as hypercapnic. So it's a type 2 respiratory failure, and the chest X-ray shows a flail chest segment, and flail chest is one of the causes of type 2 respiratory failure. And the reason for that is your chest wall is compromised. So one side of your lung, or quite a large segment of your lung, paradoxically moves, so you don't get air into that side of the lung. And therefore you're breathing really quickly, really hard to try and sustain your saturations. And over time, just like in acute asthma, these patients become really tired and they just obtund. And so the treatment of flail chest is either early intubation or it's ventilation with NIV, or sometimes Cpap, depending on their ABG. So I'm really happy that one of you kind of selected that, because that's really excellent. That's a really, really fantastic response. You should be very pleased that you got there. The people who prescribed IV morphine for pain relief, also fantastic, because the management of rib fractures is adequate pain relief. But here we've got a really bad ABG and we've got a flail chest segment, so we can't ignore those bits. Chest drain and the needle decompression would only be in the pneumothorax, which we didn't see on the chest X-ray. And no one chose Cpap because that's type 1 respiratory failure. That's good. Okay. And then this is question 6, and then we'll go on to kind of some explanation. So a nurse bleeps you as they're concerned about a 71-year-old man admitted with acute shortness of breath and leg swelling. He's been started on furosemide infusions and was previously stable, but now his breathing has become much harder. His observations are temperature 36.9, heart rate 118, blood pressure 120/67, respiratory rate 36, SATs 92% on 15 litres. His ABG results are a pH of 7.41, which is normal, a PO2 of 12.5, a PCO2 of 3.4, lactate of 2.4, which is normal. Sorry, the PCO2 was low, was normal. Lactate is reasonable. The bicarb is reasonable, and the base excess is normal. Cool. We've got 3 answers so far. We'll give it another 10 seconds. We've got 8 people. 9 people. Oh, lots of people changing their minds. Stick with your gut. Oh. Okay, 5 seconds, guys. Cool. All right, I'm going to stop it there. Okie dokie. So the answer was, in my mind, it commenced Cpap. But I can see where people were going for chest X-ray, and that's perfectly reasonable. Quite a few of you went on to Venturi as well. So we'll go through the answer. Okay, so no kind of surprises about what the presentation is here. So this guy's got heart failure and pulmonary edema, right? I mean, he's on the treatment for pulmonary edema, furosemide infusion, and it's just not working anymore. So his breathing has become much, much harder. He is on 15 litres of oxygen and he's saturating 92%, and it's bad. The PO2 is 12.5, which, as we said, was normal in a normal person on room air, but on someone in 15 litres is not normal. So that, again, is a relative hypoxemia. This is based on someone that I saw as an F1 as well. So it's pretty distressing when you see people like this. So presentation consistent with acute decompensated heart failure and pulmonary edema. They're already on medical management, but it's progressed and they're now in worsening type 1 respiratory failure. And if you don't do something about this soon, this patient is going to drop their GCS, they're going to become hypercapnic, and they're going to need intubation. BiPAP may be required. What are the answers? Commence BiPAP. Okay, so that may be required if they fail CPAP, but at this stage it's not indicated, and that's why that's not the right answer. The Venturi mask, there's no evidence of over-oxygenation there. In fact, if anything, that is under-oxygenation, and there's nothing in the history that suggests COPD. So I wouldn't go for a Venturi. Chest X-ray is completely reasonable, and you probably would do it in clinical practice, but you would need to do it alongside trying to fix that problem, because that's the problem that's going to cause all sorts of havoc for you. And you probably already know what the diagnosis is. So you know it's pulmonary edema already. So we need to do something about that oxygenation. And the GTN infusion, you can use that in acute heart failure, but they're already on a furosemide infusion. And if you give them a GTN infusion as well, you're going to drop their blood pressure and their cerebral perfusion is going to go down and they're going to syncopize. Okay, so I thought I'd go through the difference in CPAP and BiPAP because this confuses the hell out of me. And having worked in ICU and respiratory, I feel like I might be fairly qualified to kind of talk about it. And I've done so many animations that you're just going to have to stick with me now because I've done them now. So CPAP and BiPAP. You might have heard the way to remember it is BiPAP. So bi is 2. So kind of biannual, kind of all those kinds of things. So it's got 2 in the name, so it's used for type 2 respiratory failure, whereas CPAP doesn't have it in the name, so it's used for type 1 respiratory failure. And that's pretty much how I remember how to do it. And then the way you remember type 1 and type 2 respiratory failure on the ABG, type 1 respiratory failure, there's one thing wrong on the ABG, which is the oxygen. In type 2 respiratory failure, 2 things wrong on the ABG, oxygen and carbon dioxide. CPAP provides continuous positive airway pressure, and it splints the airways and prevents atelectasis, so the collapsing of those alveoli when you breathe out, and it maintains your gas exchange by keeping the airways splintered. So when you breathe out, your alveoli collapse like this. With CPAP, when you breathe out, we push air in and we splint that alveolus so it stays open. And that way you can still exchange carbon dioxide and oxygen in that alveolus. That's how it works. And that's why it improves your oxygenation. In BiPAP, so it provides 2 types of pressure. One is inspiratory pressure, which can be thought of as an assisted breath, and the other one is an expiratory pressure like CPAP to prevent collapse of the alveolus. And what this does is it improves your tidal volume, which is why it improves carbon dioxide expulsion, because it's maximizing the amount of gas exchange that you take kind of in one breath and over the course of a minute. So in BiPAP, when you breathe in, we push air in and we open up that alveolus, and that helps increase your tidal volume. And then when you breathe out, that alveolus is going to want to collapse, so we push air in and we keep the alveolus open. So hopefully that's the kind of difference between them, and that's why we use them in different use cases. BiPAP increases your tidal volume, and that is key to making sure that you expel as much carbon dioxide as possible. So question 7. An 82-year-old female with metastatic lung cancer is referred to palliative care for further management. At present, she has mild shortness of breath on 2 litres of long-term oxygen therapy, that's LTOP, and some airway secretions. She complains of back pain and is using Oromorph every 6 hours. Her current medications include, and then all that stuff there. And the question is, what's the next most appropriate step in her management? Cool, I'll give you guys about 20 more seconds. We got one answer so far. Okay, cool. 5 more seconds and I'll close it. Okay, 3, 2, 1. Okay, so well done to the majority of you. So the answer here is to increase her modified release morphine and to increase her Oromorph as well. And we'll go through the answer. So this is basically a, do you know how to calculate pain management? So when you've got someone on palliative care, the main thing is to keep them comfortable, all right? And obviously you have to bear in mind the kind of risk benefit of obtunding them with opioids and giving them an opioid overdose. But you'd be surprised how much morphine someone can take without actually having an overdose, particularly if they're taking it for a very, very long time. So the key thing here is she is taking an Oromorph every 6 hours and she's still got pain. So her pain is poorly controlled. So we need to look at what we can do to improve that. They're already on MST and they're on Oromorph. So if you calculate it, she's using 40 milligrams of Oromorph per day for her breakthrough. And the breakthrough pain, the Oromorph is supposed to be used for breakthrough pain. So what the MST is supposed to do is it's supposed to basically make you pretty much pain-free. And then the Oromorph is just when you have kind of acute pain because you've got up to go to you've gone out in the garden, or you go into shops, or late at night you have difficulty sleeping because you've got a metastasis inside your vertebra or whatever. So that's just for breakthrough pain. We shouldn't have to be using it on a regular basis. So we need to increase that MST dose so that's actually controlling her baseline level of pain. And the way you do that is you add up the total morphine that they're having every single day. So here it would be 30 milligrams times 2 because she's on MST 30 milligrams BD, and then it would be 10 milligrams times 4 to take account of the Oromorph. And that's 100 milligrams a day of morphine that she's needing. Then you give that total daily dose as BD modified release morphine. So she should need 50 milligrams BD MST. And then for the breakthrough pain, typically what you do is you give 1/6 of the daily dose. So in this case, it would be 15 milligrams PRN, because actually it's 16.7, but really difficult to get 16.7 milliliters of oromorph into a cup. The only thing that you need to bear in mind sometimes in real life is when you've got people who are having oromorph like every 2 hours. And so if you calculate it, you should be putting them on kind of MST of like 80 milligrams BD and an oromorph of whatever, like 20 milligrams. If you jump really far, so if you increase their morphine really by quite a lot in one go, that can be where you overdose someone by mistake. So often what you need to do there in clinical practice is you kind of go up by stages, probably like every couple of days, until you get up to that level. And you might find that actually their pain is controlled at a lower level of increase. But this is fairly reasonable amounts of morphine. Cool. So question 8. 46-year-old female attends clinic complaining of bilateral lower limb pain. It started 3 months ago in her feet. She describes the pain as a burning sensation with occasional tingling. The pain is worse at night when she is lying flat to sleep. Her past medical history includes ischemic heart disease, hypertension, type 2 diabetes, chronic kidney disease, and gout. And you've got her current medications there. On examination, she has reduced sensation and proprioception in both feet, and her pulses are intact. What is the next most appropriate step in management? Cool. I'll give you guys 20 more seconds. Got 3 answers so far. Cool. 10 more seconds. 5 seconds. 3, 2, 1. Okay. So the answer here is to measure the HbA1c. So well done to the majority of you. Very well done. Some of you fell into my dastardly trap of starting amitriptyline. And some of you fell into my even more dastardly trap of requesting a CT. Right. So bilateral lower limb pain, burning sensation, tingling, worse at night in a diabetic with ischemic heart disease, with reduced sensation and proprioception. So there are lots of things that this could be, right? This could be diabetic neuropathy. This could be peripheral neuropathy of any other cause, so kind of B12 deficiency. This could be vascular, so it could be arterial disease, it could be chronic venous insufficiency, all sorts of things, right? Could be nerve root compression, so it could be sciatica, all these kind of things. We know she's a diabetic, right? It's not peripheral artery disease because her pulses are intact. And we don't know anything about the status of her feet to think, or her legs to think that it is chronic venous insufficiency, although that's fairly reasonable as a differential diagnosis. But we kind of, when it looks like a horse and it sounds like a horse, you kind of got to think it's a horse, right? So we know she's diabetic. She's on metformin, empagliflozin, and insulin. So she's probably not very well controlled type 2 diabetic because she's on insulin as well as other medications for her hypoglycemia. So we don't know whether this is going to be chronic venous insufficiency, a vitamin deficiency, or your bog standard diabetic neuropathy. The management for diabetic neuropathy would be things like duloxetine. Amitriptyline you can use for neuropathic pain, but we need to know what the cause of the pain is first. So the first step we should do would be to look at HbA1c. And apologies, I changed the question away from urine ACR as well, but you would do that at the same time. So CT venogram, we don't have any evidence of chronic venous insufficiency. And remember, kind of SBAs are all about trying to tempt you into seeing things that aren't there. Serum uric acid, yeah, none of you went for that. Fantastic. Amitriptyline, very helpful if we can find a cause and the symptoms persist, but not at the current point in time. Okay, so pain management very quickly. And again, you guys can just use this in your own time for learning, but you separate it into nociceptive and neuropathic pain. So nociceptive pain, all the things that you guys do when you accidentally stab yourself or stab your foot on the end of the bed or punch each other in the face or whatever it is, right? So those are the kind of aching, cramping, somatosensory pain that you get from real injuries to your soft tissues. Right, neuropathic pain is that compression, electric, burning shock, shooting, tingling sensation that people get when their nerve roots are impinged or when they've got a neuroma and things like that. So in terms of clinical assessment that you would do, always think about what pain medications they're already on, what allergies they have, because almost everyone will tell you they're allergic to morphine. It makes them vomit. And liver and renal function as well, because some of these drugs will affect their renal function and their liver function. And then nociceptive pain is the stuff that you know about. So it's the WHO pain ladder. So you just climb up that pain ladder until you start controlling their pain. Neuropathic pain, you've got some choices. There are some preferred choices. So we very rarely give people gabapentin and pregabalin now, just because so many people got wound up on it long term. It's quite addictive. It's not fantastic analgesia for most people, and it can lead to lots of problems. So we tend to shy away from those now. We give amitriptyline, and duloxetine is an SSRI that you can use, licensed for use in diabetic neuropathy. SNRI, it's an SNRI, not an SSRI. And that's how it works. Cool. Question 9, and I think after this one we'll move on to the cardiothoracic stuff. So 58-year-old is brought into ED with palpitations. An ECG is performed, which you can see. His palpitations started this morning and gradually became worse. He's now complaining of central chest pain and dizziness with palpitations. He's got a past medical history of high cholesterol, hypertension and depression. He currently takes amlodipine, atorvastatin and sertraline. His observations are temperature 37.2, heart rate 132, blood pressure 94/68, respiratory rate 24, SATs 98% on room air. Okay, and I'll give you guys 15 more seconds. We've got 3 answers so far. No one so far has picked the refer to cardiology answer, which is good. You'd be surprised how many people would be like, refer to cardiology. Okay, cool. We'll give 5 more seconds. Okay, I'm going to close it now. So get your answers in if you want to. Some people changing last minute. Cool. All right. So only 5 people answered that one. So I'm going to guess we need to go through this a little bit. So the answer is synchronized DC cardioversion. And before we move any further, the dreaded ECG is atrial fibrillation, right? So it's regularly irregular, can't see any definitive P waves, or if you can convince yourself you can see P waves, so maybe that's a P wave, they're not consistently correlated with the QRS complexes. So those are just fibrillatory P waves that you can see there. All right. So the key thing here is palpitations, AF with a fast ventricular response rate, central chest pain, and dizziness. So that should set off alarm bells in your head, because anyone who's got a cardiac arrhythmia, who's got symptoms with that correlate with ACS or syncope, should alert you that this is probably compromising their cardiovascular state. So, according to the Resuscitation Council guidelines, synchronized DC cardioversion should be performed in all patients who present with 4 basically adverse features, and that's acute MI, which is defined as that central crushing chest pain radiates down the arm up into the jaw, or any kind of symptoms that correlate with acute MI. So, you know, chest pain with severe nausea and vomiting, sweating, all those kinds of things. Acute heart failure, so that would be pulmonary edema mostly. Shock, and that would be cardiogenic or hypovolemic shock, or syncope, so if they pass out for no apparent reason, right? So the central chest pain and dizziness reflect myocardial ischemia and near syncope. So all the other things that you guys chose on that list, apart from refer to cardiology, were fairly reasonable things to do in AF. In fact, they're all things that you would do in AF. But Chaz-Vascan has bled, you do it after you've managed them acutely. Bisoprolol, rate control drug, often first line in AF, but not in patients who've got compromise. Digoxin, again, rate control drug, used in AF, predominantly in the elderly or those with heart failure. And it's not always great. Digoxin is a bit problematic, digoxin. So again, I'm not going to go through this in massive amounts of detail, but this is again from my notes as a finalist, and these are the Resuscitation Council guidelines in a way that kind of helps me to understand them, right? So whenever you see someone with a fast heart rate or a tachyarrhythmia, you always do an ABCDE and you think about reversible causes, okay? So think about that AF. AF can be acquired as well as something that you just have paroxysmally. Or have they taken anything like a drug, like that prolongs their QT interval and has given them a cardiac arrhythmia? Then you assess for adverse features in your A to E. So as you said, acute myocardial infarction, heart failure, shock, syncope. If they've got any of these things, you should be cardioverting them. And when you do this, please make sure it is synchronized cardioversion, because if you don't synchronize it, you'll put them into kind of VF or torsades, and you can give them up to 3 shocks. If that doesn't work, then you fast boot cardiology and go, oh, this is really bad. This guy's really unwell. And you can start an amiodarone infusion. And the amiodarone infusion for every arrhythmia is always the same, which is a 300 milligram IV bolus, and then an infusion of 900 milligrams over 24 hours. If they're okay and they don't have any adverse features, then you look at the ECG. If it's a broad complex tachycardia, then you're looking to see whether it's irregular or it's regular. Broad complex tachycardia, then you look to see whether it's irregular or regular. If it's regular, it's probably pulsatile ventricular tachycardia, and that's when you can give amiodarone. If it's irregular, you should call cardiology, because that's probably abnormal atrial fibrillation. So it's atrial fibrillation with kind of bundle branch block or pre-excitation, and that's not something that you should be managing. So if you see a broad complex tachycardia that's irregular, call cardiology. I think you can also have Wolff-Parkinson-White with aberrancy or something like that. So it can be all sorts of weird and wonderful things. If it's a narrow complex tachycardia, then you're looking at SVT or atrial fibrillation. SVT, you guys know, you do the vagal maneuvers, and then you can give IV adenosine. They always need to be on cardiac monitoring with IV adenosine. Right. Atrial fibrillation, beta blockers or calcium channel blockers, or digoxin or amiodarone. Okay. And there's no question on it, but I thought I'd also put this in. This is a management of bradycardia, which is exactly the same here. So if they have adverse features, you give them the atropine that you guys will know about. And then if they don't respond to that, you can give them another atropine, or you can pace them. The isoprenaline and the adrenaline stuff I have never seen outside of a cardiac ward, so I don't know how widely they're used, but I have seen pacing. So if they don't respond to the atropine, normally we kind of pace them until we can kind of get cardiothoracics or cardiology to come and help. If there are no adverse features, then you've got to think about, well, what's the risk of them going to asystole? And these are all the things that can increase your risk. So recent asystole, complete heart block, Mobitz type 2, and ventricular pause of more than 3 seconds. So if you see those, then you need to think about maybe pacing them. And then you do the long-term management as well. Most of these people probably need a permanent pacemaker. Okay, so what do cardiothoracics do, and what can you be asked about? Start session. Cool. So cardiac surgery and thoracic surgery. That's what cardiothoracics do. So in cardiac surgery, you've got aortic aneurysms, so that's thoracic and abdominal aortic aneurysms, although vascular surgery will often do the abdominal stuff. Coronary artery bypass grafts or cabbages, heart transplantations and ventricular assist devices, all those kind of funky things, open heart surgery and valve replacements. Thoracic surgery, things they mostly do, lung resections or lobectomies, transplantations, pneumothorax repairs, so things like pleurodesis, and rib fixations. Okay, most of that is done through VATS, and this is VATS here. And that's kind of like laparoscopy for the chest, which is pretty cool. Okay, so there's a different QR code for this session. So if you want to scan that one, and I will drop the code into, if I can get it, which is often more difficult. There aren't as many questions here. Okay, so question 1. 47-year-old male is admitted to hospital with pleuritic chest pain and acute shortness of breath. He's got a past medical history of COPD and he's a current smoker. He states he developed a cough and shortness of breath a few days ago. While at work today, he developed a sharp pain on the right side of his chest and his breathing has now become worse. Observations are all there for you. His bloods are there and his ABG is there. So the HB is normal, white cells fairly normal, neutrophils fairly normal, hematocrit slightly raised, MCV is raised, and CRP is pretty much normal. Now, I think I may have changed the chest X-ray since I last wrote the question. So the pain, I should say, is not on his right side, but on his left side. I think I changed the chest X-ray, so I'm sorry. So it's on the left side of the chest. Cool. So I'll give another kind of 15 seconds. We've got 4 answers. Cool. 1 more to go. Okay, we'll stop it there. Cool, so well done. It's pretty split between giving 15 litres and inserting a chest drain, but in this instance, the chest drain was the right answer. And what we'll do is zoom in here, and I'll say the reason that it's on the left side is because when you're comparing a chest X-ray, you always compare side by side, or pretty much anything you compare actually, just side by side. And here on the left side at the top, can I convince you that this is more transparent or darker than this side? And there aren't any kind of fuzzy line kind of lung markings there. In fact, it looks pretty clear. Whereas if you go down here, it's all kind of fuzzy and you can see lots of vasculature going all the way to the edge here. And then if you follow them, you can see this kind of line that comes down here. Oh, sorry, you can't see my pointer, can you? So you can see there's a line that kind of comes down here where the lung markings kind of end, and that's your pneumothorax. So chest X-ray is a left-sided pneumothorax. We haven't measured it, but we can be pretty sure it's more than 2 centimeters, and it's making the patient short of breath. So given the fact he's got COPD, it's likely that he had a subpleural bleb, which is like a little kind of cyst of air that can burst and then causes a spontaneous pneumothorax due to his smoking and his COPD. So according to BTS guidelines, we should put a chest drain in, and if that doesn't work, then he might need to have a VATS. And an ongoing air leak, because kind of when I worked on respiratory, people just said to me like, oh, he's probably got an ongoing air leak, as if like I knew what that was. And I just kind of nodded my head and be like, yes, ongoing air leak. So basically, if you have a pneumothorax, you've got a rupture in your lung. And over time, that rupture can heal. And then the air that you breathe in doesn't escape from your lung into your thorax. And your pneumothorax will, the pneumothorax will resorb over time. Right, so the air will get resorbed back into your tissues over time. If you've got an ongoing air leak, that rupture in your lung hasn't healed. And so when you do continuous chest X-rays, even though they've got a chest drain in, the chest X-ray may show that the pneumothorax is the same as it was yesterday. And that means that the amount of air that you've taken out has just gone back in, or it means that your chest drain is blocked or not in the right place. But an ongoing air leak is when they're just kind of breathing in and all the air is still going into their thorax. And that's when you need to pleurodese them with a VATS, because that's not going to seal on its own. Okay. So pneumothoraces, collection of air within the thoracic cavity, either due to penetrating trauma or an air leak within the thoracic cavity. So key points in the history, obviously acute shortness of breath, pleuritic chest pain, risk factors, and are they shocked? So in tension pneumothorax, they can go into shock. Examine them. You get asymmetry of chest wall movements. So in this patient, the left side will be rising slightly lower than the right side. Absent breath sounds over the area of the pneumothorax, and hyperresonance. Hyperresonance is quite difficult to distinguish clinically, but definitely absent breath sounds definitely are quite easy to pick up. Often precipitated by small trauma, vigorous exercising, or binge smoking, which I have seen before. And it's separated into primary and secondary pneumothorax, depending on whether the patient has got underlying airway disease or not. So a primary pneumothorax are people who are previously fit and well, and the management is based on management of all of them is based on 2s basically. So if you remember 2, then you're probably in the right ballpark. So if it's 2 centimeters or less, measured from the kind of edge of the thorax to the lung markings, or the patient is asymptomatic and it's a primary, then you can discharge them and review them and do that classic thing of, don't fly in a plane for a couple of weeks. If it's more than 2 centimeters or they're symptomatic, so they're requiring any amount of oxygen or they're visibly short of breath, then you can aspirate it with a needle. So that's when you do your kind of needle aspiration, which almost always in my experience doesn't work very well. And then if that doesn't work, then you have to put a chest drain in. For a secondary pneumothorax, those patients with restrictive or obstructive lung disease or lung cancers or previous operations, blah, blah, blah. If it's 1 centimeter or less, then you admit them for oxygen and you observe them, because sometimes it gets bigger and they need more intervention. If it's 2 centimeters or less or they're asymptomatic, you aspirate it, and if that doesn't work, you put a chest drain in. Or if it's more than 2 centimeters or they're symptomatic, like our guy was, then you just stick a chest drain in. Right. With the chest x-rays themselves, you're always looking for absent lung markings, normally at the top, a visible lung edge, which this one's got, and if it's tension, tracheal deviation away from the side. If it's a non-tension and it's a particularly large one, you might see the trachea deviating to that side, just under the weight of that collapsed lung, pulling that trachea over. And then in trauma, you always need to look for subcutaneous emphysema, that kind of popcorn, that kind of popping bubble wrap kind of sensation that you see in the subcutaneous tissues, and trauma or rib fractures. And here is a BTS guideline for you, so you don't have to go look it up. So that's basically just a more complicated version of what I've put. Cool. Question 2. So 71-year-old females brought into ED resus following a low-speed RTC. So that's a road traffic collision. She was driving her car when she collided with a tree. She denies any loss of consciousness. She has left-sided chest pain, worse than inspiration, but is able to complete full sentences. On examination, her chest is clear, her heart sounds are normal, her capillary refill time is normal, her GCS is normal, her blood glucose is normal. The ECG demonstrates normal sinus rhythm with no ST changes. A chest X-ray and bloods are performed. So the observations are all fairly normal. She's got slightly tachycardic and she's on 2 litres of oxygen, and her bloods are fairly normal. CRP is marginally raised. What's the most appropriate next step? Cool. I think that's everyone. And then we've got 2 more. Cool. All right. So the answer was perform a 24-hour ECG. And again, this goes back to kind of like the always remember you kind of bread and butter medicine. And that's the kind of reasoning behind this question. So some people put discharge with follow-up, perfectly reasonable. Set a chest drain. I'd like to know what you're going to drain, and then request a CT chest, which is what most people went for, which again, completely reasonable as well. So if we look at this chest X-ray, there's no pneumothorax because you can see lung markings all the way to the edge. There's no visible lung edge here. But if you go down, you can see a rib fracture. Can't use that. There's a rib fracture there, and there's a rib fracture there, and there's a rib fracture there. So she's got some rib fractures. It's not the end of the world. There's no subcutaneous emphysema. There's no pneumothorax. There's no hemothorax anywhere. So these look like simple rib fractures. The key question here is, why did she crash her car? Because most people don't drive around and then just suddenly collide with a tree. And what you will learn when you kind of start doing F1 jobs is that if patients say, "Oh, I didn't lose consciousness," it doesn't mean that they didn't lose consciousness. It just means that they don't remember losing consciousness. So we need to think about, why did this person drive her car into a tree? The most common causes would be things like, is she diabetic and she had a hypo? Did she have a stroke? Did she have a heart attack? Does she have a cardiac arrhythmia that gave her syncope? Or, does she have visual impairment that we need to investigate? So we need to think about, why does she actually present to us in the first place? The rib fractures and stuff, we can manage that with adequate analgesia, and none of the answers on the SBA dealt with the kind of rib fracture side of things. So we need to do our due diligence and do a 24-hour ECG. Discharge and follow-up, so I put inappropriate given the risk of pneumonia. So she's on oxygen at the moment, and we probably shouldn't be discharging anyone who's requiring 2 litres of oxygen to saturate. Chest drain, not indicated. No evidence of infection, especially antibiotics. And CT chest, we don't think there are any other traumatic injuries. There's obviously nothing on the X-ray to suggest an occult pneumothorax or any other problems. And you don't need to do any other investigations for the rib fractures. Cool. So rib fractures, most of them are managed with just appropriate analgesia and chest physiotherapy. So you can classify them as non-displaced, displaced, or flail chest segments. All right. And we normally do a chest X-ray. If we think there's any other trauma or they're very complex rib fractures, then you might do a CT chest. They're actually sometimes more difficult to see on CTs, actually. And then if it's an acute presentation, so high-speed RTC, and you think there might be a hemothorax or a pneumothorax, but you can't see it on the chest X-ray, then you can do this thing called an EFAR scan, which is an ultrasound scan of the lungs, and you can see fluid and you can see pneumothorax there. The complications, the most common is pneumonia, because it's so painful that you don't take a full breath in. And you normally have atelectasis of the kind of lower alveoli, so basal atelectasis, and that provides a breeding ground for bacteria, and you get a pneumonia. If it's traumatic, you get pneumothorax, hemothorax, or aortic or cardiac injuries. Very rarely aortic and cardiac injuries. So on this chest X-ray, you can see lots of rib fractures there, and you can see a nice fluid level there. So that's a fluid meniscus level. So this patient has got hemothorax. Management, we normally just give them analgesia. Lidocaine patches are super popular. I think the evidence about whether they work or not is a bit sketchy, particularly in elderly people, but people get them nonetheless. Posterior nerve root blocks are incredibly good for rib fractures, and opioids as well. If they need oxygen, give them some oxygen, and chest physiotherapy is going to get them back on their feet and also teach them to properly cough and breathe in deeply. If they've got really complicated fractures, consider early surgical fixation and early ventilation, because as we saw, the flail chest problem, it can result in type 2 respiratory failure. Cool. Question 3. And we've only got 2 more after this, so we're almost there. A 31-year-old female sees a GP due to increased breathlessness. She describes a 1-year history of progressive shortness of breath following a COVID infection for which she was not hospitalized. She's able to walk upstairs but has to take a break to catch her breath. She was otherwise previously fit and healthy. She denies any cough or fever and has a recent negative urine HCG. She does describe tightness in her chest on occasion, particularly when doing housework or going upstairs. When she was a child, she had childhood eczema and takes antihistamines in summer for hay fever. And during her COVID infection, she had a brief fainting episode, but thinks it was due to dehydration. So which of the following is most likely to confirm the diagnosis? Cool. All right, we've got 5. So let's go. So very difficult question, I think, this one. So what I've gone for here is echo, and we'll go through the reasoning why. So a young lady with progressive shortness of breath is always a bit of a red flag. So causes of progressive shortness of breath will be things like restrictive lung diseases, neurological diseases, so things like myasthenia and things like that, and also things like heart problems. Okay. She's able to walk up the stairs, but has to take a breath to catch her breath. So she's got exertional shortness of breath. And before this, she was perfectly fit and healthy. She has no cough. So that's the key thing here when you think about asthma. So there's lots of stuff in here that you could fit into an asthma diagnosis. Tightness in chest sometimes, shortness of breath sometimes, but there's no cough, and asthma normally manifests with the kind of diurnal variation of symptoms, coughing, wheezing, tightness in the chest. And the other thing that's suspicious is when she had an infection, she fainted. She thinks it was due to dehydration, but that should kind of raise alarms in our mind about why did she faint when she had a COVID infection, which was not that serious and she didn't have to be hospitalized for it. So this is kind of suggestive of, or is compatible with, aortic stenosis or HOCM. So you would think about asthma, COPD, PE, restrictive lung diseases. However, there's no exertional, asthma doesn't really present with exertional chest tightness and progressive shortness of breath and diurnal variation, as we said. So the peak flow and the spirometry would diagnose asthma, but probably less likely in this case. All right, CTPA would diagnose PE, which is very possible, especially given a COVID infection and in a young female who may or may not be on contraceptives. But there's no DVT symptoms, and this is a very, very long history. And then CT aorta is for aneurysm or dissection, which is really not likely. So again, really, really hard question. So please don't feel disheartened if you didn't get that. And we'll go through valvular heart disease, but we'll probably go through it quite quickly, and I'll let you go through these on your own. Heart murmurs are the bane of almost every doctor's and medical student's existence because they are really, really difficult to hear, and they're probably even more difficult to figure out what's going on when you hear them in real life. So I'm only going to focus on the main ones that you kind of see. So that's things like aortic stenosis and mitral regurg, and those are also probably the serious ones that we tend to do stuff about. All right. So this is just to remind you what happens in diastole and systole, and I'll talk you through the pathophysiology. So essentially, when you've got aortic stenosis or mitral regurg, when you are in systole, the stenosis kind of prevents the amount of blood that you can pump out of the heart. So it increases your left ventricular afterload. So you're not able to expel enough blood out of this left ventricle. So you're left at the end of systole with quite a lot of blood in there. And then in diastole, you've got more blood coming in to fill up that ventricle, which is why it results in dilated cardiomyopathy in the long term, because you keep pushing, you keep ending up with loads of blood in there. The ventricle has to dilate to accommodate a lot of that blood, and often it becomes hypertrophic as well. So the muscle becomes thicker to try and push that blood out. The preload increases as a result, and then your ejection fraction results in you have a lower ejection fraction, resulting in a reduced stroke volume. So when you start exercising, you can get hypoperfusion, and you can get syncope, and you can get angina. So you don't have enough cerebral perfusion, you don't have enough coronary artery perfusion, so you get symptoms of angina and syncope. Obviously, because the pressure is built up in this aortic, in this left ventricle, that can feed all the way back through the pulmonary circulation, and that can result in pulmonary edema and ultimately right ventricular heart failure, because the right ventricle can't pump against the pressure of all that backlogged blood. Right-sided pathologies, mostly ASD and VSD, and tricuspid regurgitation. Right, so in tricuspid regurg, so you have reduced blood flow to the left ventricle, because when you're in systole and that blood is pumped out of the right ventricle. Some of it is going back into your right atrium, so you have less blood going into the left ventricle. So that results in reduced stroke volume because there's less blood in that ventricle during systole. As a result, it also increases the preload in that right ventricle because your end systolic volume is increased because you haven't pumped enough blood out. You pumped it back into the right end atrium and it's going to get pumped straight back in. So in this, you can get right atrial dilatation. You can get hyperperfusion again because you're reducing your left ventricular blood flow. And obviously all the pressure builds up back into the vena cava. So you can get congestive hepatomegaly, which you overfill is something that you'll never forget, and peripheral edema. So congestive hepatomegaly is hepatomegaly that has a heartbeat. So when you feel the liver, you can feel systole going through the liver because all that pressure is going through the liver and it's pulsatile. And I thought I'd talk about ASD and VSD because I've actually seen it on the wards, and it can be quite tricky to diagnose. They're very, very common. About 50% of people have ASDs and they're just walking around. VSD is slightly less common because they get diagnosed mostly at birth or in early age. But ASDs can manifest kind of in your 60s and you don't know about it. They're often asymptomatic because obviously the left-sided pressure is greater than the right, so you get a left to right-sided shunt. But under stress, that can reverse and it goes from right to left, and that's called Eisenmenger's syndrome. And that can be due to, say, a pulmonary embolism in your pulmonary circulation that increases the pulmonary pressure, and so builds up the pressure back into the right ventricle until this pressure is greater than the left side, and then stuff starts flowing from right to left. Can also be due to restrictive lung diseases and things like that. Problems you get, so you get heart failure, and you get paradoxical emboli. So you get DVTs that kind of go into the heart, go into the left side, shoot off and give you a stroke. So paradoxical emboli. But the cool thing, or the thing that you may see if you see symptomatic ASDs, is this thing called orthodeoxia or platypnea, which I won't go into like really long detail. But basically, when the patient sits up, their breathing becomes worse, and when you lie them down, their breathing becomes better. And it is the opposite of orthopnea. And the reason for that is when you sit them up, their right ventricle is unable to perfuse adequately their pulmonary circulation because most of the blood is going to this kind of left side. And when you sit them down and you've got gravity working in your favour, their oxygenation is often better. And it's one of those things that if you see it in a patient, you should think about ASD and VSD. And I won't go through this because you guys hopefully know all this and you can go through it in your own time. But the management of valvular heart disease can be medical or it can be surgical, and it's often dependent on how severe it is and how symptomatic it is. So if it's very severe or they're very symptomatic, you normally go for a surgical replacement. For things like a TAVI or a TAVR, so that's a valve implantation, valve replacement. I should say this about beta blockers in aortic stenosis. If you give a beta blocker to someone who's got aortic stenosis, then what you do is you reduce their heart rate and you reduce their stroke volume. So you've already got someone whose heart is really struggling to pump blood out of their aorta. If you reduce the heart rate even more, you can drop their stroke volume even more, and it can cause all sorts of problems. So hypoperfusion and things like that make things worse. You don't really use it unless it's in critical care. And then the things like anticoagulation, so it varies, and often the best thing to do is look up what the INR targets are for different valve replacements, because they can be tricky to keep in your mind. And sometimes the surgeons will change them and say, I want this patient to have an INR target of kind of 2 to 3 or 3.5 to 4.5 or whatever. But in general, if it's a metallic valve, then they need anticoagulation for life. And the target for aortic valves would be 3, and for mitral valves would be 3.5. If they have a bioprosthetic valve, so one made of tissue or synthetic tissue, they don't normally have to have lifelong anticoagulation. They normally have it very short term for about 3 to 6 months. But in some patients, you know, in real life, you may be asked to continue their anticoagulation. Okay, question 4. 52-year-old man admitted to ED with reduced consciousness. His wife found him collapsed on the bathroom floor this morning after he had been complaining of chest pain. He regained consciousness on scene, but has been confused and agitated ever since. His past medical history includes ischemic heart disease, high cholesterol, hypertension, and sciatica. He had an acute myocardial infarction 4 weeks ago and was started on ramipril and bisoprolol. His A to E assessment, he's got equal air entry with an inspiratory rub. His heart sounds are quiet but present. He has a raised JVP, a prolonged capillary refill. He's cold and clammy to touch, and he has a reduced GCS. Cool. Okay, we're going to race through these last two because we've only got 2 more people on the we've got 3 people now on the quiz. Cool, so I'm going to close that. So answer was C, request an echo. And what we're going to do here, although to be honest, okay, we'll go through why the fluids is not right. So this patient is showing something called Beck's triad. So Beck's triad is a collection of symptoms or examination findings that are emblematic of cardiac tamponade. So distended neck veins, muffled heart sounds, and hypotension. All right. Other things that you'll see on past medicine are things like electrical alternans on the ECG, and you can also see things in the JVP that can also indicate cardiac tamponade. In practice, they're incredibly rare, and only when the patient is probably on the verge of passing away. So the electrical alternans you probably will never see. It's a surgical emergency and it needs to be confirmed with an echo. So that can be an EFAR scan or a POCUS. POCUS is a point of care ultrasound. And then either a pericardiocentesis, so that's draining the pericardium of all the fluid, or an immediate thoracotomy to repair the root cause and drain that blood out. If the blood has been there for a very long time and it's coagulated, a pericardiocentesis can be pretty naff because it flows for about 2 seconds and then it gets lodged with a clot and it doesn't empty anymore. So a lot of the time, I think thoracotomy is normally what's indicated. So the reason the fluids aren't the correct answer is because it's tamponade. So this patient is in cardiogenic shock. So if you give more fluids, you're going to overload the heart even more, and it's not going to be able to pump, and you're just going to risk causing other problems. So things like pulmonary edema or worsening peripheral edema. So the reason that their blood pressure is low in this case is because the heart is being compressed by blood. So pericardial fusions and tamponade. So there's an accumulation of fluid in the pericardial sac that compresses the heart and causes tamponade. On a chest X-ray, you will see a globular water bottle silhouette of the heart. And on an echo, so this is a transthoracic echo, you get the classic 4 chambers view. And then you get all this dark fluid around it. So normally the heart should be sat right against here, and there should be no blackness in between. So this is your pericardium, and this is your pericardial sac, and this is just fluid inside the pericardial sac. And you can see the right ventricle is almost collapsed. The left ventricle is not very big at all. So this effusion is already compressing on the heart and making it very difficult for that heart muscle to pump blood around the body. And that's going to be the main problem. So the causes, so heart or renal failure, just because of transudative causes, transudative effusions. Malignancy, because of the inflammatory or exudative effusions that can happen with malignancy. Pericarditis, and what's been handed over to me is always think about TB if you have a pericardial effusion with pericarditis. And if you do a pericardiocentesis, take a sample and a biopsy to look for infection and to look for TB. Very common post-CABG or post-cardiac surgery because of all the inflammation, and post-MI, which is what this guy had. So he had a free wall rupture, or kind of you can say it's Dressler's syndrome, or you can say it's probably free wall rupture. So in a free wall rupture, you've got myocardial ischemia that weakens or makes part of the ventricular wall very thin, and then it can result in a rupture and a very rapid effusion and tamponade. And obviously being stabbed in the chest is also, of course. All the symptoms: central chest pain, shock, fever, shortness of breath. Signs: pericardial rub, never heard it before. A Beck's triad, in fairness, also never seen it before. You normally just see that their blood pressure is a little bit low. Investigations: you need to echo it to confirm. You can get a CT thorax if they're severely unwell. I wouldn't. And you can get a cardiac MRI, an ECG, a chest X-ray, troponin to rule out other causes as well. The management: if it's not causing any problems and they're post-surgical or it's infection, you might just monitor it. So you might do an echo every couple of days and see whether it's getting bigger. Your main management is going to be fix the cause. So if it is infection, you need to fix that. And a pericardiocentesis or a thoracotomy, as we said. Okay, I'm not going to go through this because this is the management of shock. So you guys can go through this on your own. This should be fairly straightforward. And then here you've got a diagram of kind of the 4 different kinds of shock and what can cause them. Okay, last question. So 36-year-old female attends ED with persistent epigastric pain for 4 weeks. She describes a persistent central chest pain that is dull and worsens on exertion and becomes sharp. The pain can radiate to her back and to both arms and often makes her breathless. She denies any cough, fever, wheezing or syncope. Her current medications include desogestrel, omeprazole, sertraline, and an ECG shows normal sinus rhythm, and her observations are all fairly straightforward. What is the next most appropriate step in management? Cool. All right. Okay, I'm going to stop it there because you've all answered. Fantastic. So some of you went back and forth. So the answer was to request a chest X-ray, and the other most common answer was to request a CT aorta, which is absolutely fair. But remember, stepwise management. So cardiac chest pain. Everyone who's got cardiac chest pain should have a chest X-ray to exclude other causes. So that's the reason why it's a chest X-ray. So anyone with chest pain needs to have other causes excluded, even if you're very smart and you know this sounds like a thoracic aneurysm. So most aneurysms are completely asymptomatic, which is why they're so problematic. But when they become symptomatic, the symptoms are persistent chest pain that can radiate to the back, the arms, the jaw, and associated breathlessness. So essentially things like ACS. And this is for thoracic aortic aneurysms. The other answers are not correct because increasing sertraline is for anxiety attacks, and that's not indicated. CT aorta is diagnostic, but not the next step in the investigation, particularly given the kind of age and female sex in terms of radiation exposure. Echo, they can show aneurysms in the aorta, but they're very difficult to see and very operator dependent, so they're not definitive. And the esophageal pH monitoring is for GORD. So, thoracic aortic aneurysms, and I'm going to admit that I'm not an expert in any way, shape or form on these things. They are much less common than AAAs, and they're mostly associated with genetic risk factors, and those are essentially connective tissue diseases, smoking, and family history. So you tend to see them in elderly people, but you can also get them in very, very young people. People with chronic hypertension, people with smoke, people who've got a family history. And then the connective tissue diseases that would alert you to this would be Marfan's and Ehlers-Danlos. You can classify them in different ways. You can classify them based on where they are and how far they stretch, or you can classify them on the Crawford classification. Sorry, this is dissections and aneurysms. So you basically classify them by where they are, or you can kind of classify them by where they're most common. So the ascending aorta is most common, and then the descending aorta is next most common. Very uncommon to have one of them actually in the aortic arch. We talked about the symptoms. Sometimes they can get a hoarse voice and SVC obstruction, and that is from the compression of the aneurysm on the recurrent laryngeal nerve or on the SVC, depending on where it is. So that's something to look out for as well. And then if it progresses and it perforates or it dissects, then they get confused, hypovolemic. They've got a blood pressure differential between their left and their right, depending on where in that aortic arch it is. And they can have a radial delay or a radiofemoral delay, again, depending on where that dissection and that aneurysm is. And the management for it, very basically, if they are small and they're asymptomatic, it's lifestyle advice. So stop smoking, control blood pressure. If they are symptomatic and they're fairly small and they're not indicated for surgery, then you can manage them with beta blockers. Or if if they are symptomatic or they're very large, then you can do a TEVAR, which is endovascular aortic repair, so thoracic endovascular repair. If you're just monitoring them, then vascular surgery will normally do a repeat CT aorta just to make sure that they're not getting any bigger. All right, and thoracic aortic aneurysms, the criteria for repair: anyone who's symptomatic or anyone with a pretty large aneurysm, 5.5 or 6. Abdominal aortic aneurysms, you're much more likely to be examined on, and the criteria for repair there is 5.5 centimeters and above, or rapid expansion of more than 1 centimeter in 1 year. Cool. All right, that was a very, very long session. I apologize that it took so long, but thank you for bearing with me. I hope those questions are useful. Do run through them with the explanations again. And if you do have any questions, you feel free to ask me now, or you can always send me some questions and I'll be happy to answer them.